We'll start today talking about some of the common orthopedics emergencies, and it's going to only be practical bullet points in early care. So we are not going to provide so much information or definitive treatment or how to do the treatment or the approach or etc. or some of the techniques, but we are going to give just the practical points that will help you during your own calls, during your busy calls, so you know how to deal with the patient, and you have an idea of how you are going to respond or react to the case you are facing or the call you are receiving. Okay. For further information, definitely you need to go and read more in different sources. Okay. So these are some of the topics that we'll cover today. It's common ULC, open fractures, compartment syndrome, some of the joint dislocations, definitely septic arthritis, and we'll talk a little about Coda equina syndrome. So if you receive a call from an emergency doctor and telling you, orthopedic guy, I have an open fracture, please come and assess. At this time, you tell him, baby, please calm down. We'll sing the song for that. When you ask for more further information before you accept the case and to be the primary care for this case, okay? So you'll ask what is the mechanism that he's having, what he had. If it has a high energy mechanism, definitely we'll do an ATLS protocol, and you need to look for what other injuries he has got. This open fracture and usually it's a high energy mechanism, so you need to know what other injuries he's having, and definitely ask him, did you assess the distal neurovascular? If he has a vascular injury, could you please call a vascular surgeon to come and assist and to be involved in this case? Okay, and ask him, did you give antibiotics and tetanus according to the case? All these simple steps and simple questions will save time and will give you more time to read and focus on the patient care as well. Okay. So what to do? Once you go to see the patient, definitely you'll do your assessment again for the patient as a whole and for the local injury in particular. If you saw any gross contamination, means you saw gross dirt, stones, foreign bodies, anything, just remove it and simple wash for the wound. You don't need to go for 3 liters, 6 liters, or 9 liters according to Gastello, because this to be done in emergency and operation room, okay, in the sterile area. And if you found any piece of bones, don't remove it. Just keep it in the wound as it is, okay? Then definitely you will find some deformity of the limb. You can do just realignment. Realignment means you maintain the rotation and you maintain any angulation and you maintain any shortening that's happening to the bone, and you stabilize the fracture with a back slab, okay? And for the wound, you apply single gauze that's soaked in saline over the wound to keep the wound moist, and this soaked saline will absorb any bleeding and will يعني بيحفظ البليدنج داخل السوكت جوز هذه عشان ما يطلع برا و disrupting any cotton layers and the crepe bandages. Okay. Make sure that the patient has received the appropriate antibiotic according to the fracture energy and the Gastello classification, and make sure that he received the tetanus as well. And after you do all that, go and reassess again. Okay, reassess the neurovascular again, reassess the wound, reassess the patient pain. Then you can proceed to whatever image you want to do. Okay. Everyone is familiar with Gastello classification. Gastello classification depends only on the energy. Okay, it doesn't depend on the wound size. For example, if you have a very high energy mechanism, you have an extensive soft tissue or extensive contamination. If you have a severe fracture comminution or a segmental shaft fracture, for example, but you have a 1 centimeter wounds, that means it's a Gastello type 3, not Gastello type 1. So we don't rely only on the wound. It's about the energy and that he's having to the limb. If you found the periosteal exposed through the wound, this is type 3. If you found a bony that's part of bone exposed through the wound, that's type 3. And of course, you are familiar with the A, B, and C subtypes of type 3, which B needs soft tissue coverage, and C needs arterial. There is an arterial damage that needs a repair, needs to be repaired. Okay. And Castello will guide you through the antibiotics that you need to cover. For example, type 1 and 2, you need cefazolin is fine. Type 3 will need to add gentamicin, and special consideration for some freshwater or farm injuries, you need to add antibiotics according to. General rules in orthopedic and in open fractures, you need to do frequent assessment. You need to assess before and after any intervention you will do, and you might do every 2 hours. You assess for compartment syndrome, you assess for the vascularity as well. Definitely you need to examine and have an X-ray of the joint above and joint below. If you have a femur fracture with an open wound communicating with a fracture, this is a type 3 because the femur is a large bone and there is a lot of soft tissue, so you need a really high energy trauma to have an open fracture of the femur. So it's directly Castello 3. Some guys are arguing about this, but at least you know that open femur fracture, it means an extremely high energy mechanism. Okay. If you have any wound in the hand or foot, it's a deep wound. No matter you saw it, how simple it was, but it's a deep wound, and you need to look for the soft tissue involved. Okay. Antibiotics, try as much as possible to be given within the first 3 hours to decrease the risk of infection later on. And definitely you will prepare the patient for operation, as he needs definitely irrigation and debridement and some sort of fracture as stabilization according to, and this to be done within 24 hours or 12 hours for Castello type 3, where there is need defect in soft tissue. If you open fracture stayed without operation for more than 24 hours, then you convert it to Castello type 3 and you choose your antibiotic according to. Okay. So compartment syndromes, we know all limb of our body has some muscle groups, and each muscle groups contained within fascia. That's called the compartment. If anything, increasing the pressure inside the compartment or causing decrease in the space from, for example, outside compression, this will cause a compartment syndrome. It's increased intracompartmental pressure. Okay. We all know the 5 P's: pain, paresthesia, pallor, paralysis, and pulseness. And you'll also see the patient has demanding the analgesia, and you'll find him anxious and agitated. But regarding the 5 P's, you know it only to know that pain is the only P you will see, and the other P's, paralysis, pallor, paresthesia, pulselessness, these all are late finding. So if you saw a patient with pain out of proportion, pain with passive stretching, and he's one of those who are having risk factors for compartment syndrome, anyone for fracture, crush injuries, gunshots, if you have a tight cast or dressing, someone called you from the radiology that the patient was having, for example, IV study, CT with IV contrast, and he started to have pain at the injection site, any arterial injury or bleeding disorders. So if you have a high suspicion of compartment syndrome and you have clinical finding, please, what you need to know is your senior phone number. You need to call him. Please, I have a suspicion that I have a patient with query compartment syndrome. Please come and assess him with me, because you need this compartment syndrome to diagnose it. You need only a clinical judgment. Okay, your senior will have better information and better experience, and will confirm your diagnosis and prepare the patient for OR, or he will observe as well. Okay. If you have any cast that's tight or tight wrapping, please release it and elevate the limb and give the patient analgesia and see if he improves or not. Okay. But this is after the patient being assessed with you. If you want to do a bivalve, عزام ممكن تصمت تسلم. If there is a cast and you want to do bivalve, please release the internal cotton as well, okay? Because bivalving the cast without releasing the internal cotton, you didn't do anything. So joint dislocations, you'll commonly see the shoulder and elbow, hips and knees in the lower extremities. Definitely you need to assess before and after any intervention, assess for distal neurovascular. There are multiple reduction maneuvers. Please know one or two of each joint and try to experience it as much as possible. Some joints you need to test for stability after reduction. And definitely you need to immobilize the joint and look for any associated injuries or fractures. For example, the shoulder dislocation, we all know the traction, counter traction. You do the traction in line with the patient limb, and someone will do the counter traction. After confirming the reduction, you need to do X-ray 3 views at least. So you confirm that the shoulder is in place. You will immobilize him in arm's length and try to avoid elbow stiffness. Tell him that don't keep your hand immobilized with arm's length all the time. Release it from the arm's length. Do elbow active flexion and extension, and then you can put it back. For elbow dislocation, this is one of the maneuvers I found really good, where I have the patient his hand over his body, and the one who's doing the reduction will be standing here on the right side. This is the right hand. He's standing on the right side, and he's trying to relocate the olecranon in place with his thumbs, and the other guy will do traction. After doing reduction of the elbow, you need to test the range of motion to see the stability of the elbow. Is it stable or no? Then you will immobilize him in pronation or supination according to what ligaments is injured. Is it the LCL or the MCL? Okay, and definitely you need X-rays to look for other associated fractures. For hip dislocations, this is the Alice maneuver, the most commonly used. We'll do 90-degree hip, 90-degree knee, and you do longitudinal traction. Then you need to test for stability. You do flexion up to 90-degree, and if there is any dislocation through this range of through this arc, or there's any dislocation again with any adduction or internal rotation, this is considered unstable hip. After reduction, put him on skin traction, and please always do CT post reduction. Okay. Why? You confirm that it's a concentric reduction, you confirm that there are no associated fractures, and you will see if there is any loose bodies intra-articular. Okay. For knee dislocation, it's really a critical thing. Assess the neurovascular for the lower limb, and then inform your senior directly that I have a knee dislocation. Okay, because these kinds of dislocation will have high rate of vascular injury. So you'll see every joint has its own risk and informations that you need to read, its own maneuvers that you also need to practice as well. Septic arthritis, those are usually the patients who are having a high risk, any immunocompromised or comorbid patients, any patient with bacteremia or recent joint surgery. What's usually the patient is going to complain of? Fever, warm, red, swollen joints. The joint is resting in maximum joint volume. For example, the knee, you will find the knee is resting in 20 to 30-degree flexion. You will find the hip resting in flexion, abduction, and external rotation. It's called the Faber position. You will find that the patient is not tolerating any passive range of motion, and definitely he will not be able to bear weights. So what we will do, you will order investigations as soon as possible, CBC, ESR, CRP. You will do X-ray for assess any bony lesions, and then you will do ultrasound for the hips, for example, if it's a deep joint, but if it's the knee, you don't really need to do it. And the most important thing to do is joint aspiration. Each joint has its own technique. You can find it in NETR, Concise Orthopedic Anatomy. It's talking about each joint and the multiple techniques for aspiration or injection as well. Once you aspirate, look for the color of the aspirated fluid. Is it frank pus? Is it the normal synovial fluid? Is it traumatic hemarthrosis? Then you will send the fluid that you aspirated for cell count, glucose level, culture and gram stain, and crystals. If you aspirated a frank pus, or if you have a cell count of 50,000, or you have a positive culture and gram stain, so this is septic arthritis that you need to take the patient to the OR, do irrigation and debridement as soon as possible, and please involve the internal medicine for choice of the IV antibiotics, as most of the patients are comorbid. One thing happened in one of the centers. They were suspecting that the patient having septic arthritis. They aspirated and they found the WBC count was only 5,000, but they didn't know that this patient having joint prosthesis, he had a total knee before. And once you have a total knee or a joint, then the chapter is moving from septic arthritis to prosthetic joint infection. It's a totally different chapter with different diagnostic criteria. Okay, please consider this in your mind. So the Coda equina syndrome, we all know that the spine is ending in L1 vertebra. Then you will have a lot of nerve fibers. They are called the Coda equina, the Hisan. Anything will compress the Coda equina, for example, a fracture of the vertebra, a disc, a tumor, collection, anything is compressing on the Coda equina, it's causing the Coda equina syndrome. How to know that? The patient will complain of acute back pain with radiation to lower limb. You will find a history of trauma or pushing or lifting heavy objects. You will find an examination saddle paresthesia in the perineum area and the internal thighs. And you will find that the patient is complaining of urinary retention, where the bladder is full on palpation, but the patient cannot urinate. Definitely, when you need to do dermatome and myotome assessment for the lower limbs, and you will assess for the bulbocavernous and anal wing tests. Excuse me, معلش بس دقايق. سامحوني. كنا بنتكلم عن الابسنت bulbocavernous reflex وابسنت anal wing. This is the bulbocavernous reflex. If you are squeezing the glands of the penis or stroking the clitoris while you are doing a digital rectal exam, you will find an involuntary contraction of the anus. That's the normal. If you did it and you found that the anal, there's no anal tone or there is no anal contraction, this means there is an absent bulbocavernous reflux. Okay, this is confirming the diagnosis of Coda equina. If you did the anal wing test where you are doing a pinprick around the anal area, you will find that there is a voluntary contraction. That's the normal. If there is no voluntary contraction, that means this is a sign confirming the Coda equina syndrome. Then if you are suspecting what you are going to do, please inform your senior as soon as possible. Prepare the patient for MRI and prepare him for urgent surgical decompression within 48 hours. As I said initially, this is only practical bullet points in what you are going to face. So for the Coda equina, you need to know what are the dermatomes and myotomes for examination. What's L1, what's L2, what's L3, what's L4. For the compartment syndrome, please involve your senior as it's a clinical diagnosis. For the joint dislocations, you can do all of them by you. by yourself. But if you have a knee dislocation, please inform your senior as soon as possible. If you have a septic arthritis, you need to know that you need an aspiration to confirm your diagnosis. And there are multiple techniques for aspiration. You can learn 2 or 3 of them and stick to it. For the open fractures, you need to realign, and please observe for the compartment syndrome as well while the patient admitted. Okay, don't admit the patient and leave him without frequent observation. طبعا زي ما انتم شايفين محاضرة جدا قصيرة وصغيرة لأنه فيها a lot of knowledge يعني، وكل محاضرة الواحدة المفروض تاخد time lecture on its own. بس هذه only practical points to what you are going to face and what you are going to do and what's your initial plan that should come directly into your mind.